Okay, we'll get started with our next speaker, Dr. Joe Nelson. For those of you that don't know, Dr. Nelson is the state of Florida medical director. He has been involved in emergency medical services for more than 35 years, beginning here in Lakeland, Florida. That's right, he's a local gentleman. Began in 1970 as an ambulance attendant. Realized his true passion for EMS, board certified emergency medicine, and is nationally recognized EMS expert. In 2016, he was awarded the title of Distinguished Fellow by the American College of Osteopathic Emergency Physicians. Please help me welcome your state medical director, Dr. Joe Nelson.
Thank you. Thank you very much. Good to see old friends. Hey, Carol, how are you? All right, I'm going to talk for a few minutes about compassion in EMS. And we're going to go through a few examples of how we might be showing compassion in our care. It's not a sexy subject like Dr. Abo had, but I think it is an important subject. It's a subject that we deal with every day. We have the opportunity. You don't have the opportunity to treat a snake bite every day. You don't have the opportunity to treat a black widow spider envenomation every day, but we do have the opportunity to provide compassionate care every single day with every patient. I'm going to start with a quote from Nelson Mandela. Our human compassion binds us the one to the other, not in pity or patronizingly, but as human beings who have learned how to turn our common suffering into hope for the future. And that's kind of what it's all about. So a few issues I picked to exemplify compassionate care. We're going to talk a little bit about family participation in resuscitation, in cardiac arrest. Talk a little bit about the do not resuscitate issues, and we're going to talk a little bit about burnout in EMS and how dealing with that is going to help protect you from being sued. So let's talk about resuscitation first. And that says, if you can't read it, you're not doing much for my confidence, you know, as the guy's digging the grave, digging the hole while they're working on the patient. Case 1. And I'm going to go over here so I can read my notes. You have a 58-year-old man who's collapsed at home on a Saturday. You're called for a man down. You arrive at the scene to find CPR in progress by a neighbor who happens to work as a patient transporter in a local hospital. The patient's wife is standing nearby. Her eyes are red. She's obviously worried. She tells you that she came home from the store and found her husband on the kitchen floor. So what now? Well, you take over CPR. You do all the magic that we do. You place an eye gel airway. You put an intraosseous needle in his left leg. You look at the monitor. The monitor shows a systole. The patient's wife asks, "Is he going to live?" And really, the question at this point is, should you let her remain in the room and watch? How many of you have had family members observe the resuscitation? Most of you. How many of you have had a negative interaction as a result of letting the family members observe in the room? A few of you. Okay. The fact of the matter is, family presence during CPR is still somewhat controversial, but there have been a number of studies that show that we probably should be doing more of this. In this study that on the slide now, there were 570 relatives of patients who were in cardiac arrest that were given CPR by 15 pre-hospital EMS agencies. The units that were randomly assigned to systematically offer the family member the opportunity to observe or to follow the standard practice and not allow observation. And roughly the 570 families were roughly 50-50. About 50% of them observed, 50% of them did not. Then they did some analysis of immediately and then down the road several months on what the outcomes were in terms of stress, etc. What they found was the relatives who did not witness CPR had symptoms of anxiety and depression more frequently than those who observed the CPR. Family witness CPR did not affect resuscitation outcomes, did not affect survival, the characteristics of the cardiac arrest resuscitation, or the level of emotional stress in the medical team, and did not result in medical legal claims. So the conclusion of this study was that family presence during CPR was associated with positive results on the psychological variables and did not interfere with medical efforts, increase stress in the healthcare team, or result in medical legal conflict. In fact, the 2015 AHA guidelines for CPR and emergency cardiac care recommends allowing families to witness the resuscitation. And they go on to say, family members with no medical background have reported that being at a loved one's side and saying goodbye during the final moments of life was comforting. Family members have also reported that it helped them to adjust to the death of their loved one, and most indicated that they would do so again. So their recommendation of the AHA, in the absence of data documenting harm and in the light of data suggesting that it may be helpful, offering select family members the opportunity to be present during a resuscitation is reasonable and desirable, assuming that the patient, if an adult, has not raised a prior objection through some sort of advanced directives. And this is a Class 2A level of evidence C for adults and a Class 1 level of evidence B for pediatric patients. There have been a number of studies on pediatric patients that also support this concept. So, my recommendation is that you attempt to let family members observe CPR. Of course, there are going to be exceptions. If you have someone who is just so distraught that they can't, that they're going to interfere, it might be best to have that person moved out of the room, away from the resuscitation, maybe with another family member to comfort them, etc. But in most cases, I think you should consider allowing family members to observe CPR. Let's talk about advanced directives now. I found this slide. It was pretty cute. It says, actually, we're an alternative ambulance, and you've got a guy there with who's mixing a potion in a bowl, and you have another one up there with acupuncture needles. So I thought, well, maybe we should try that, you know. But we're going to talk about advanced directives. So case 2, end of life. You're called to the residence of an 86-year-old man with end-stage COPD and pneumonia who is under hospice care at home. His brother, who just arrived today from out of town, called 911 when he got there and he saw the patient was struggling to breathe. You arrive at the patient's side. As you arrive, the patient stops breathing, but he still has a pulse. The patient's brother then raises his voice and says, "Oh my Lord, help him." The patient's adult daughter, who has been been there caring for him throughout this entire ordeal, states emphatically, Dad doesn't want anything done, let him go. How many of you have been in a similar situation? It's tough when you have two loved ones of the patient with differing opinions on what should happen, isn't it? So I'm going to try to talk a little bit about how we can look at the legal documentation for some guidance here. So what do you do? What actions do you take? Who do you listen to? What information do you need to help you make a decision? Who's the designated healthcare surrogate? That's one thing you might want to know. Does a living will make a difference if they have a living will? Does a DNR or do not resuscitate order tell you what you should do? Because now you have a patient who's not breathing, but they still have a pulse. So it gets kind of murky. Well, let's look at advanced directives first. In Florida Statute 765, there's a definition of an advanced directive. It means a witnessed written document or an oral statement, interestingly enough, in which instructions are given by a principal, meaning the patient, or in which the principal's desires are expressed concerning any aspect of the principal's health care or health information. Advanced directives include such things as a designation of a healthcare surrogate, a living will, or if somebody wants to donate their body to science, that would be considered an advanced directive as well. We're going to talk specifically about the living will. That's under 765.302 in Florida statute. First of all, any competent adult can sign a living will. It directs providing, withholding, or withdrawal of life-prolonging procedures in the event that that person is in a terminal condition, has an end-stage condition, or is in a persistent vegetative state. Living wills may also be revoked, or they may be modified, and there's procedures in the law for doing both of those things. A living will, it's interesting because you go back to the statement I said before about oral, written or oral, but then the law kind of contradicts itself by saying that a living will must be signed in the presence of two witnesses, one of whom is neither a spouse nor a blood relative. A living will establishes, and this is what's in the statute, a rebuttable presumption of clear and convincing evidence of the principal's or the patient's wishes. Rebuttable, meaning you can argue it. The one other thing I want to point out was that an advanced directive executed in another state is recognized in the state of Florida. So if you have a patient who the family pulls out an advanced directive from Illinois or Kansas or California, you can legally recognize that device. When we start talking about DNR orders, there is also some allowance for that in the law. So, if a living will is present, if they've made a living will expressing their desires concerning life-prolonging procedures, but they have not designated a surrogate to execute those wishes, the patient's primary physician may proceed as directed by the principal in the living will. Primary physician. In the event of a dispute or disagreement concerning that decision to withhold or withdraw life-prolonging procedures, the primary physician in legal terms, shall means you will do this. There's a big difference between shall and may. In the law here it says shall. Shall not withhold or withdraw life-prolonging procedures pending a review under Florida statute, blah, blah, blah. If a review of a disputed decision is not sought within 7 days following the primary physician's decision, the primary physician may then proceed in accordance with the instructions. So a couple things I want you to focus on in this language. First of all, the physician, the primary physician, it doesn't say the EMS physician, it doesn't say the paramedic, it doesn't say the registered nurse, it doesn't say the family member. The other thing is they clearly have a process for handling disputes, but that dispute can take up to 7 days. So I would submit that in a case of a resuscitation at a home, a living will probably isn't going to do much good other than help us, guide us in what we should do. It's not going to tell us what to do. The other thing is in terms of determining their condition, which has to be terminal, end stage, or persistent vegetative state, the primary physician and at least one other consulting physician must separately examine the patient. So what are you going to do? You're on the scene, you got a patient who's stopped breathing, they still have a pulse. You're going to call the primary physician and then find another doctor to come to the house and determine? No, this isn't going to work. So these findings must be documented and before that decision is made. So I don't think that a living will is going to do us much good here. It may be a general guide to their wishes, but it's not going to really tell us what to do in this case. So what about a do not resuscitate order? Do not resuscitate order is in Florida statute. It's in 401 in the EMS section. Resuscitation may be withheld or withdrawn from a patient by an EMT or paramedic if evidence of an order to not resuscitate by the patient's physician is presented to the EMT or paramedic. So it says may. Again, it's not shall, it says may. An order to not resuscitate to be valid must be on the form adopted by the rule of the department. That's the one that you all are all familiar with. It's the yellow, I call it the yellow ticket, or the golden passport to an eternal rest. And it must be signed by the physician and the patient, or by the patient's designated proxy. One thing that's important here is you are kind of covered no matter what your decision in this case. Any licensee, physician, medical director, EMT, or paramedic who acts under the direction of a medical director is not subject to criminal prosecution or civil liability, and has not engaged in negligent or unprofessional conduct as a result of withholding or withdrawal of resuscitation from a patient pursuant to the law. So you are protected from liability if you stop resuscitation or choose not to resuscitate if this DNRO is present. You can't be sued. They can't file an administrative complaint against you. One of the most common reasons cited in administrative complaints against EMTs or paramedics is unprofessional conduct. That's a very broad catch-all phrase. It can mean not following protocol. It can be any number of things, but unprofessional conduct. Well, you're specifically protected from being accused of unprofessional conduct when it comes to do not resuscitate issues. There is a rule, every time you have a statute, then you can have rules written under that statute that further delineate, explain, add more detail to the circumstances. And 64J has rules under the statute. And it says that an EMT or paramedic shall withhold or withdraw CPR upon the presentation of an original or completed copy of the Do Not Resuscitate form, that during each transport you shall ensure that a copy of that DNR form goes with the patient, and that you still shall provide comforting, pain relieving, and other medically indicated care short of respiratory or cardiac resuscitation. The other issue is they talk about medical direction. Any licensee, EMT, or paramedic who in good faith provides emergency medical care or treatment within the scope of their employment and, of course, within the scope of your licensure, pursuant to the written or oral instructions of a medical director, shall be deemed to be providing care under the Good Samaritan Act. So it's an additional broad protection for you, liability protection. So my recommendation is when you have these situations, if you're in doubt, contact your medical control and get their instructions, or look to written protocol for what you should do. In Florida, the Florida Do Not Resuscitate order includes patient's cardiac or respiratory arrest. So you could, in this case, not resuscitate the patient. You could, because it's a respiratory arrest. They don't have to just be, they don't have to be apneic and pulseless. Simply apneic could trigger the Do Not Resuscitate order. So back to the case. So what should you do in the best interest of the patient? My recommendation in this particular case would be to begin BLS until you have your answers clarified in the case. And if a valid DNR order is presented, I would not intubate that patient. I would provide care and comfort. I would continue BLS, and I would contact medical direction to help you decide how to proceed at that point. In general, though, understand that you do have strong liability protections for whichever way you decide to go. You do have protection. So in this case, that's what I would do. I would start BLS. I would try to discern who has the, who the surrogate is. I would do everything I could, and I would contact medical direction and see what they say. And it's probably going to be a case-by-case basis. All right. There is some hope on the horizon because these situations are very sticky sometimes. I think that there's a form called the POLST, or Physician Ordered Life-Sustaining Treatment Form, that may be a better answer. It's not yet recognized in Florida statute. They tried to get it through this past year in the session that just ended, and it didn't make it. I think it was just a matter of having too many bills to try to get through the Florida legislature during the session. There were over 3,000 bills filed this year in this legislative session that just ended a couple weeks ago. Over 3,000 bills were filed. Only 300, 10% of them, made it through to a vote. So the odds weren't very good. Could the recognition of POLST possibly be accomplished through local protocol or rule, though? Maybe your medical director can consider that. If the medical director, going back to what the law said about written or oral direction, if it were in protocol, you might be able to honor a POLST. And in fact, they're doing that in Palm Beach. In Palm Beach County, through an effort between a couple local hospitals who've decided to start using the POLST form and county medical direction, they are recognizing the POLST forms as a DNR. I think they're also filling out the DNR on those patients as well. But the POLST form gives a lot more detail in what the patient wants done. And it's not nearly as vague as a living will. In the form that was been proposed and is in fact being used in a number of states and has been voted in as a legal document, the first section has to do with CPR, and it essentially covers the standard DNR order. Yes, attempt resuscitation or do not attempt resuscitation. And if they're not in cardiopulmonary arrest, then follow the orders in the next section, and those sections go into more detail on other medical interventions. And I won't go through all of that, but the point is that this document gives much more clear guideline and detail as to what the patient's wishes are. So it's, I think it's a good thing. So there is, I've lost audio I think, but can you hear me okay? Yeah. All right, so there is a website. There are a lot of websites, but there's both a national and a state website for POLST. If you want to learn more about it, to talk a lot more about how it came about and where the national efforts are going, and that information is available here on the slide. All right, let me talk for the last section about compassion and burnout. Now this paramedic on the slide obviously is not burned out yet. It says, the paramedic saying, "Don't give up, fight damn you, why?" And the female medic says, "You gonna tell him that the leads fell off?" And the other medic says, "Nah, he's on a roll." So he's not burned out. So case 3, I call it the LOL and NAD, the little old lady in no acute distress. You're asked to transport a 75-year-old woman from ABC long-term care to St. Excellent Emergency Department for replacement of a gastric tube. It's 11:30 at night. This is your 11th call today since coming on duty at 8 a.m. and you've had no food since 2 p.m., which was a hastily devoured tuna sandwich from the Fast Mart and Quickie food store. Your patient's vitals are stable. She does not speak since her stroke 4 years ago, and she doesn't interact with you. Her patient gown is soiled from where the G-tube came out. There's been some leakage onto the gown when she pulled it out. Of course, no nursing assistants are anywhere to be found at ABC Nursing Home. Does this sound like a familiar situation? One that we've all seen. You know, this isn't a life-saving decision, but the question is, should you change her before you transport? Should you help protect her dignity a little bit and simply change her? I think you should. If you're burned out, you may not. The term burnout was identified 30 years ago to describe a state of fatigue and frustration among healthcare and service workers arising from excessive demands on their resources. Emotional exhaustion is one of the 3 central constructs of burnout. You feel emotionally drained and exhausted by your work. Depersonalization, which results in negative or detached feelings toward patients. And the third thing is reduced personal accomplishment. You evaluate yourself negatively and you feel unsatisfied with the positive job performance and achievements. So that's the definition of burnout. The consequences of burnout are significant. It has a large potential negative consequence for the individual, for the patient, and for the healthcare workforce. For the EMS provider, it can cause clinically significant mental health problems, headaches, sleep disturbances, hypertension, anxiety, alcoholism, myocardial infarction even. For the patient, it can result in suboptimal care. For the workforce, for your employer, for your EMS agency, it can cause sickness absence of employees from the workplace and ultimately intent to leave the profession. It can drive people out of the profession. And we all know that in EMS, we need to retain our workforce. So we need to tackle this problem. EMS lawsuits. Lawsuits against EMS services are relatively infrequent. And individually against EMTs or paramedics, they're even less so. And this was a statement by Page, Wolfberg, and Worth, which is probably one of the most preeminent legal firms in the country dealing with EMS law. Probably one of the recognized group of experts in EMS law. And they're saying it's not too frequent, but I will tell you it's getting more frequent. EMS lawsuits are going up. However, again, very seldom is the EMT or paramedic named individually in these cases. The other good news is you do have quite a bit of immunity. It's easy to file a lawsuit. Anybody can file a lawsuit. It is relatively hard to carry that lawsuit to a successful conclusion in Florida especially, because you have a number of statutes that protect you. If you work for a government agency, you have a liability limit. And that liability limit, the payout is not high enough to entice some attorneys to go after a case, to pursue a case if it's kind of questionable. So it's harder if you work for a government agency to be sued. Most legal actions against EMS are actually for motor vehicle accidents. So your driving safety issues are probably the most common cause of causing an EMS agency to be sued. Many, many fewer are for medical negligence. Many, many fewer. 911 dispatch is becoming an increasing source of liability. What happens when a caller picks up the phone and calls 911, the way that call's processed and handled is becoming more common, just so you know. But you are normally wearing a white hat. When you're called, generally the family, the people on the scene are anticipating your arrival. They have called you looking for help, and you're generally good until you prove yourself to be bad. So I think that, you know, again, you're wearing a white hat at the very get-go, so use that to your advantage. If you have a bad attitude, it translates to lack of compassion. Virtually 95%, again, this is from Page and Wolfberg, 95% of EMS lawsuits in their studies, the root cause related to a bad attitude by the EMS provider. Rudeness, laziness, and communicating effectively are major contributors to dissatisfaction of patients and families, and therefore to lawsuits. Burnout leads to a bad attitude and to lack of compassion. So what I've tried to do here is tie together how burnout can lead to legal action. And of course, if you've ever been through a legal case where your agency, you've had to get up on the stand, you've had to go through hours of depositions, that's not going to help your attitude toward EMS very much. So you can see how you can compound the problem, starting with a bad attitude and making things even worse. Lawsuits have, another source says, lawsuits have little to do with physical harm to the patient and much to do with the relationship. In this case, it's a study talking about physicians. Physicians' behavior and relationships with their patients, rather than any other single medical mistake, contributes to claims being brought against them. I would submit to you that EMS is no different, that the same principle applies to EMS. So it is something that if we can mitigate burnout, mitigate having a bad attitude, remember a few basic principles, I think we can help protect ourselves and our employer and our careers and our licenses by not getting into a legal mess. So, to reduce risk, first of all, be compassionate. Remember, we're going back to compassionate care in this talk. Be compassionate. Show the patient that you're sincerely concerned about his or her complaints or concerns or issues. Be competent. A competent EMS provider knows when to seek medical direction consultation, for example, when the patient isn't getting better as quickly as you expect, or when the patient's presentation is atypical or it's something that you haven't encountered before especially. Be quick to contact your medical direction and medical consultation. I know most of the I see several medical directors in the room, and I certainly feel this way. I would much rather be called at 3 o'clock in the morning. Well, if you cannot do it at 3, that'd be good. But I'd much rather be called at 3 o'clock in the morning to be involved in a sticky case, a sticky situation, than to have decisions made that result in a bad outcome. I'd much rather intervene right then and there and try to prevent the problem from growing. Communication. Communication is essential between patients and providers, but it's equally essential, critical, between members of the healthcare team. And this isn't just your partners, the other EMTs or medics on the scene, but this is the physicians and nurses that you work with. You have to all communicate as a team in order to make sure that things that are threats to the patient's health, patient care, prevention of medical errors, that is communicated so that you can again head off things. And that includes, again, communicating with your medical direction through whatever mechanism has been set up. And then lastly is documentation. Good documentation is your best defense. Chart as though the patient will read that record, or the patient's family will read that record, and ensure that that documentation is complete and accurate. Those are things you can do to reduce your risk and prevent in terms of legal risk. All right, well, the last thing I want to talk about is the MOM test and other musings. In your care treatment, and this is what I've done for over 35 years, starting my career as an EMT and a paramedic, and through my 30-plus year career as an emergency physician. Worked in 2 level 1 trauma centers. I've worked in big hospitals, little hospitals. I've been the transferring physician, the receiving physician, and in all of this career, I asked myself, would this be the right thing for my mom as I'm trying to make my decisions? Recognize the MOM test and use it, and it will help guide you. Recognize that stress exists and be on guard for signs of burnout, both in yourself and in your coworkers. Avoid excessive alcohol and other bad stuff. Develop coping skills. And there's lots of resources out there for burnout and developing various coping skills. In fact, just today there was an article that just came out, I got it on my email, talking about burnout and talking about coping skills. It came out in the electronic version of Emergency Medical Services, I believe, magazine. And understand how your interactions with patients and family can impact your liability. So your compassion will be rewarded. Probably can't read this, I'll read it for you. St. Peter is there saying, "You obviously have performed honorably with a great deal of compassion and love for the sick and the injured. You have also," oops, what's this? Tisk, tisk. "Your patient billing forms were woefully and inadequately documented." Well, we can't all be perfect, but I assure you that if you're compassionate, you provide compassionate care, your compassion will be rewarded. So in summary, interact with your patients in a positive, supportive way. Consider allowing family observation of resuscitation. Understand the differences between advanced directives, including living wills, DNROs, or do not resuscitate orders, and eventually the POLST. Be compassionate. Use the MOM test in your daily runs. Recognize stress and burnout and take actions to mitigate them. Be passionate about your work. It really does make a difference, even to the LOL in NAD. And lastly, celebrate EMS Week. Thank you for all you do. Any questions? Thank you.